Well, welcome yet again to this Friday morning IDMP meeting. Thanks for taking the time to join again. So with that, I want to introduce the speaker for today, who is Patricia Kritek, who I will start simply by saying she was one of the most beloved medical ICU attendings here at Harvard, specifically the Brigham, before we lost her to Seattle, where she moved out to the University of Washington to become the director of the medical ICU there for a number of years before she moved on to the position as Dean of Faculty Affairs. Now, to be fair, I had asked Trish to speak several weeks ago about the crisis in Seattle and to teach us about it when they were a little bit ahead of us. But as the way things have been going, she got called in emergently to cover in the ICUs there. And so this is a few weeks later. And so they're at a different time and we're at a different time. Nevertheless, there's lots to learn. And so we definitely appreciate her joining. Trish. Oh, I should make a comment that, it is 6 o'clock in the morning. So she's not in her pajamas, but again, yes, an extra word of thank you for making the time this early for you.
My pleasure, Deb. Thanks for inviting me to join you. And it is true, it is just starting to get light here in Seattle. And it's early, but I'm happy to join folks in Boston. It's my pleasure to be with you. I'm gonna go ahead and share my screen. So it's a pleasure to join all of you. Thank you so much for inviting me. As Deb said, I am a pulmonary critical care doctor at the University of Washington. I've been out here for about 10 years after doing my training and then early time as an attending in Boston at Brigham and Women's. So I am going to share with you the Seattle experience of COVID-19. And I think the thing I'm going to say beforehand is it's really different than where you are right now. It is really interesting to me how different it is. And for those of us in Seattle, honestly, for the last many days, weeks now, it's been actually challenging to watch things happen on the East Coast and in New Orleans and other parts of the country as the experience has exploded in New York and Boston and other cities. So I have a small amount of trepidation about saying that we have something to teach you, because I think at the end of the day, folks in Boston are knee deep in it right now. So with that in mind, the things I'm going to talk about is how the epidemic has unfolded in Seattle, the areas of uncertainty and the places where we still remain uncertain, which I would say has been the hallmark of this whole experience, and then kind of next steps. And Deb sent me some questions in advance. I tried to address them, but I'll be happy to answer whatever questions folks have as we go along about what's happening here and kind of what we think in general in critical care about what we need kind of as next steps. So I'm going to start with this, which is a timeline of what happened in Seattle. And some of you may know about this because a lot of it was in the public news, but I think it's an important pathway to walk through to understand kind of where we started and how we got there. So as I think a lot of people know, the first case of coronavirus in the United States that was diagnosed, and who knows how much coronavirus was already in the country, was diagnosed here in the Seattle area. So Sonoma County is the county just north of Seattle. It's where some of the kind of suburbs of Seattle sit. And the first case was diagnosed there in a person who had come back from Wuhan. And I think that caught everyone's attention in the US. It definitely caught folks' attention here in Seattle. But mostly was still an emphasis on folks who had traveled and less around community spread. About a month later, almost exactly a month later, we had the first patient who was positive at a skilled nursing facility called Life Care, and that was all over the news. And I would say, in some ways, that was a tragic event, because obviously that ended up having a lot of patients who died, who were at Life Care. But for Seattle, I think it was a really instrumental moment for people to start taking it seriously, because all of a sudden we had a lot of folks who got really sick really quickly, and we pretty much overwhelmed one of our local community hospitals that was near Life Care, which is in Kirkland, which is kind of again a suburb-ish area of Seattle. And it woke everybody up dramatically. About 10 days later, the other thing that I think started to get people's attention was that a 16-year-old also in Snohomish County tested positive for coronavirus. And that was thanks to the Seattle flu study. So that young person had flu-like symptoms, got swabbed for the flu. We are doing the Seattle flu study for preceding this, and Dr. Helen Wu was leading this investigation to kind of understand how flu is transmitted across our community. And they made the decision to start testing for coronavirus. It was controversial. There was a lot of backlash around it. But because of that, he was identified as having coronavirus very early. And it became clear at that point that we had community spread. And that changed, I think, the perspective in the greater Seattle area very quickly. The next day, a state of emergency was called for the state of Washington. And then I think another really important step for our community was that because of those concerns, because of public health and public health engagement with the local government in the city of Seattle, as well as in King County, the county of Seattle, as well as collaboration with the counties north, Snohomish, and south, Pierce, leaders within a lot of the tech companies had everybody go home and start working from home on March 5th. This was really early compared to what was happening across the country. And at that point, on March 5th, you already started to feel a difference in the greater Seattle area of just people not being out and about. A few days later, the University of Washington stopped having in-person classes. I think that also was a powerful statement. It changed, again, how the city felt. And I think it raised this level of concern. All through this time, we're seeing more and more patients coming into the hospital, and we're seeing a high rate of mortality, mostly because we're seeing folks from skilled nursing facilities in the early phases. And I think all of that, for lack of a better word, death got people serious about making sure that we started to do things differently. So physical distancing happened very early in Seattle. The Seattle Public Schools subsequently closed. In between those 2 days, we stopped having patients have any visitors. So on March 10th, we stopped having visitors in any of our hospitals. And then as you see, eventually on March 23rd, the whole state of Washington was under order for stay home, stay safe. That means that people weren't supposed to go out unless they had urgent things to do, like go to the grocery store or go to the pharmacy. Otherwise, it was to stay at home. And what I would say is having lived in Boston for 12 years and having lived in Seattle now for about 10 years, there's some physical things that are different. For a city that's about the same population as Boston, the square footage of this area is much larger, so there's more space. Secondly, there's this phrase that people call the Seattle freeze, which is I think that my assistant dean for well-being the other day said that we're like 49th in states for extroverts. So people were more likely to gravitate to staying in. And it is a totally different city right now in terms of people being out and about. People have taken it incredibly seriously. And I think that has made a big difference, the physical distancing that we see. And I would argue that, early work by public health, early work at the state level, and then early work in collaboration with our main industries in the area has made a big difference in terms of how people in Seattle have responded to this pandemic. So I think I walked through all of this because I think this has actually been an important part of how the city has responded, and in doing so, we've seen some flattening of the curve, which I'll talk through in a little bit. We published this report, the second one, the New England Journal of Medicine report about our first series of critically ill patients. And so what I would say is, early on, we had the most critically ill patients, but there weren't a ton. The first paper that I cite here is the one that was published in JAMA. That was from that community hospital called Evergreen Hospital in Kirkland. And that's a place where they had the most ICU patients, and the majority of them came from life care, and they had a particularly high mortality. They were older patients, and I'll describe that a little bit more. And then secondarily, we published a paper in the New England Journal of Medicine that, again, only had 24 ICU patients. This was all very early, but this was a slightly different cohort. It was across multiple institutions. And there, again, we had a relatively high mortality. Both of these papers were published in the time when up to half of the patients were still in the ICU on ventilators. So it was very early in our understanding of what was going on with these patients. So the New England Journal of Medicine series that I described, that 24 patients, some of them came from skilled nursing facilities, but unlike the other series where most of those patients came from that one center, these were now folks who were coming from the community. So we were starting to see that. But you'll see that there were young folks. We had young people up, and the 23-year-old was here at the University of Washington Medical Center, up to very old folks. And the majority of them were on the older end of the spectrum. And I think that's what we're continuing to see in the ICUs, that we see young people who get really ill, but more of the folks who are getting particularly sick are older. And I think that's bearing out in lots of different cohorts of patients that we're seeing. You see a little bit of an indication of the fact that these people mostly had a higher BMI. I think that's also bearing out in other studies that obesity seems to be associated with worse outcomes, and more to be learned about that over time. And then similar to what we're seeing in a lot of different cohorts of folks that are being reported now, in this early cohort, we saw similar things in terms of risk factors of diabetes. Our folks also were enriched for having chronic kidney disease and maybe asthma. I think the other risk factor that we see in the literature now is hypertension. And so those are things that are going to put patients at risk, we think, for worse disease, and they were enriched in our critical care population that we saw early on. Now, those are the first 24 patients that we had across the region. And one thing that I will comment on is I've been incredibly impressed with the collaboration across the Seattle area. So early on, a cohort of intensivists at our two main teaching hospitals, which are both about 500 beds. They're smaller than Mass General or Brigham. They're small, they're about 500 each. And we have two community hospitals in our system. But there's a bunch of other large community hospitals in the area. And a group of intensivists started a text chain where folks were talking every day about who they had in their ICUs, what was going on with them, and collaborating and kind of thinking about how to take care of them, as well as load leveling. And through that, we've been able to share what we're learning and also kind of take care of each other, which I think has been a strength of the Seattle area. I'm going to show you some data from the UW Medicine experience. And as I said, UW Medicine is 4 hospitals that include our county hospital, Harborview Medical Center. It's about 500 beds. University of Washington Medical Center in Montlake, that's the main university hospital, that's about another 500 beds. And then 2 community hospitals, one north of Seattle and one south of Seattle. And we worked as a system across all of this to support each other and work together. So I pulled data from just yesterday of our dashboard. And so what you're going to see is this is amazingly fewer patients than you're seeing. So what you see is this starts now in mid-March, and this is yesterday. And what the blue is acute care, and what the dark navy is ICU. And you can see that for the last couple of weeks, we've really plateaued. We have the same number of patients pretty much in all of across our system. What is different, and I think you can figure this out from looking at the picture, is that we're becoming enriched for critically ill patients, less because more and more patients are presenting, and more because the duration of time on mechanical ventilation in our patients has been quite long, and our patients are not turning around quickly in the ICU. Some are getting extubated, some are getting discharged. There are definitely people getting better, but it's taking a long time, including the folks that we've put on ECMO. So we're enriched for that. I also added in, I'll talk a little bit about testing, which I think has been a big thing for the Seattle area and our success in kind of flattening the curve. You'll see that we've been doing a fair amount of community testing. At this point, we run about 9% positive on all the folks that we're testing. And for our employees, which doesn't include just people who are taking care of COVID patients, it's all of our employees who are the folks we first prioritize testing, we run about 5% positive. So what are the other things that we've done locally? Some of the same stuff that I'm sure you did. We early on converted multiple of our ICUs to all negative pressure rooms by putting holes in the walls, in the windows really, and hooking up a HEPA filter to create negative pressure rooms. We've centralized our supply dashboard across our whole system, which has helped us stay in a good place for PPE. We've trained a lot of folks to do new jobs, just like you have done in Boston. And so we created resources to do just-in-time training for people to be critical care doctors. We shared our policies locally and globally. I highlight the link at the bottom of the page where we've been kind of putting our policies out there from the very beginning to share with other folks. We created an innovations team early on with collaboration with our School of Engineering, and they're a group that's been working on different innovations ranging from 3D printed face shields to new gowns to ideas on sharing of ventilators, which luckily we've never had to do here. And then we've communicated a lot. We have a weekly town hall for the whole system. We have a daily email that updates folks. We have this website that we use on a regular basis. And we do a lot of rounding in all of our spaces to kind of check in on people and make sure that they're doing okay. The other thing we've done is we've centralized all of our research protocols across the system so that we can try to be as thoughtful and organized as we can about how we study what we're doing as we move forward. Just to talk about this briefly, I think since we were a leader in this, we spent a lot of time thinking about the ethics of a pandemic and having some concerns about getting to this point where we would be in crisis standards of care. So we have had a plan around crisis standards of care for quite a while, which would be the place where perhaps we're rationing ventilators or triaging patients as to whether or not everyone can go to an intensive care unit. And what I would say here is that we've stayed here in this contingency space where we've done things like reusing N95s after they've been decontaminated and changing some of our standard practices to adapt to the increased workload, but we have not in Seattle gotten to the point of being in crisis standards of care. And I think that has been a blessing. At the same time, we're prepared to go there and we have a system to work through that. And I'll mention this a little bit more later. We've done that in collaboration across the state and really working with our partners at other institutions so that we would decide that we would be at crisis standards of care as a state as opposed to at a single institution. But it has been a good collaboration to think through how we would deal with this. And as I said, I think we've been incredibly lucky that we haven't gotten to that place. And when I sit and talk to friends in New York City, and even, you know, Boston in some moments, I think things are closer to that than we have been at any point in Seattle. I think one of the bright spots for Seattle was really our testing. And so we were really ahead of the curve on being able to test. So I highlight here, the picture is Alex Greninger. He's a assistant professor in the Department of Lab Medicine. And he was partnered with Dr. Keith Jerome, who's the head of the virology lab, to have a test to do really early. So you can see I cut the headline out of the Seattle Times. The date of it is March 4th, which was, I would argue, way ahead of the curve. They had already created a test and they were waiting for approval to start using it. And we finally got the approval to start using it on March 4th. And we were really able to do a ton of testing early on in our labs here. We were doing testing first for patients as well as healthcare workers. And then as we had more and more capacity for the community, we've been testing on average probably about 500 folks within our system. And then we have the capacity to test up to 5,000 people in our virology lab. And so we've been helping with a lot of hospitals in the area throughout King County, Snohomish and Pierce counties to really support folks, and then also bringing in labs from further out. So we were able to do a lot of testing a lot earlier, and I think that gave us a sense of what was going on in the community a lot earlier. It also allows us to do things like we evolved to testing any patient who was coming in to have a surgery. We had been only doing emergent surgeries for quite a while, but we test every patient before they go to surgery. We test every patient who is in L&D, in labor and delivery. And now actually we test every patient who comes into the hospital. And I think it's kudos to our virology lab and their nimbleness in getting this up and running for us. I'll add that at the early phases, we had lots of tests to do and not enough people to run all the tests. In our basic science labs, there was a call out to our basic science labs for folks to help with doing the PCRs. And we had an unbelievable response from our basic science labs for folks volunteering to help do this. And we were able to kind of basically run 24/7 in our virology lab, which made a big difference. We also started doing drive-through testing very early on. I know this is something that they do in Boston as well. This was a a big part of us being able to get our employees tested. Actually, a lot of the early work was getting employees tested so that we could make sure we were keeping folks safe and keeping people who are coronavirus positive out of work. But now we do it for the community. We actually have a mobile van that now goes around Seattle and does testing associated with really trying to understand the epidemiology of the disease in our marginally housed population. And we continue to expand our drive-through testing sites. And so these are two examples of the folks that were involved in the drive-through testing. It's been a big part of us getting a better sense of what's going on across the city and the community. These are the data from our virology lab. You can see they have a daily update. You can go to their site and see it. You can see that this was data from yesterday. They've tested almost 68,000 patients, and you can see that the positivity rate runs right around 10%. And so that's a little bit different than the number I said before, 9% for our system. That's because they're testing folks from outside of our system as well. And then you can see how many they test on each day. Below, you can see that the purple is the folks there's nothing detected, and the gold is the folks who are positive. There are still inconclusive tests. We found that most of the inconclusive tests end up being positive. So we could treat those folks as positives when they test that way from our virology lab. But we still have capacity, and we still would like to keep doing more tests. And I think the thing that we're talking about now is, how do we start testing broader in terms of getting more sense of other folks who might be positive and are pre-symptomatic or asymptomatic, and that's the next space that we're kind of thinking about where we're going to go. I mentioned the Seattle flu study. I want to just call it out that the Seattle flu study evolved to be the Seattle Coronavirus Assessment Network, or SCAN, in collaboration with Public Health, King County and beyond. And this was a study that was designed to understand the epidemiology of the flu. They rapidly converted to being able to test for coronavirus as well. And we're now trying to use that same mechanism to understand the spread of coronavirus across our community. So you can see that people can sign up. They are sent or delivered a swab kit. They can self-swab, and then the results will be reported to them if they're positive, and also go into this study to better understand the epidemiology of coronavirus. I think this is a great example of collaboration between the university and our investigators, particularly Helen Chu and her team, and the Department of Public Health. And then I'll finally show you a little bit of the data from the Institute of Health Metrics, which has, I'm sure if you've been watching the news about coronavirus, have seen this in some place. So these are folks within the University of Washington who have this model that's heavily influenced by the effort to do physical distancing and the kind of stay-at-home order. So unfortunately, I didn't save screenshots of what it looked like in March, when the thought was that we would have over 1,400 deaths within the city of Seattle. This was a screenshot that I had from another talk at the beginning of April, when we thought we would have an ICU bed shortage and have a significant ventilator shortage. And this is what the curve looked like. And this is the picture from yesterday. It was last updated on the 13th. And you can see that our curve has been dramatically flattened. And we think a lot of that has to do with social distancing and our early testing. Our mortality prediction, which was over 1,400, is now down to 855. I actually think that there's going to be a new IHME model coming out later today, and it may be even different from that. But you can see that the curve has been dramatically flattened, and we're right now think that we won't have a need for additional ventilators, because we have way more than 216 across our region. And because of that, we're sending healthcare workers to the East Coast and sent back our ventilators that were offered as part of the emergency supply. I highlight the Johns Hopkins website, which I'm sure a lot of you have seen, mostly because I want to just draw out the fact that if you look over here on the screen, Massachusetts is now ahead of the state of Washington in terms of number of cases. And I think that's what we're feeling, is that you have moved ahead of us, and we are in more of a plateaued phase right now. We anticipate still having lots of patients for quite a while, but we're definitely flattened compared to where we were before. And then the last couple of things I'm going to mention for our area is that I think the other thing that has been particularly positive in this area is that we've worked as a region. So we set up something called the Regional COVID-19 Coordination Center. It's run out of Harborview. It is a way to try to address the fact that we want to be equitable across our region. It's actually now looking at the whole state, and we don't want to have any of our smaller hospitals or small groups of hospitals be particularly strained. So they work to address moving patients from hospital to hospital as needed. They coordinate those transfers to try to load level across our institutions. They have nearly daily updated data on how the different hospitals in the state are doing in terms of PPE, in terms of beds, in terms of ventilators, and they collaborate to get folks to the places that have the resources to take care of them. They've also done a fair amount of work with our skilled nursing facilities. Those are still places that are hotspots for us, with multiple places with many positive patients. And they're proactively working with those skilled nursing facilities to place patients if they need to be placed, or provide staff to take care of folks there as staff are testing positive and needing more support in terms of care of folks in skilled nursing facilities. So again, I think that this system of trying to be regional has been particularly positive in the area. So Deb asked me to talk a little bit about what do we want to know and where do we stand in terms of kind of questions, and she and I can talk about this more. I think there's some big areas that I think we'd like to understand a lot better as we continue to take care of patients. So the first one is this: where we are now in Seattle is starting to talk about, are we going to start to loosen up our physical distancing and our restraints on people going out and about? And we are still under the stay home, stay safe order until May 4th, and we're in conversations now about loosening up regulations as a state, but also trying to figure out what we're going to do as a hospital system at this point in time. So the ability to understand if people actually clear the virus and whether or not folks are immune after being exposed is, I think, one of our hottest topics, because it's important for us in terms of patients being discharged from the hospital and going places other than their home in terms of whether or not they're truly cleared, because we don't want to foster more outbreaks in skilled nursing facilities. I think we're really curious about whether or not people are immune and whether or not they're a protected workforce. And I think, every week we have a town hall that I moderate, and we take questions from the community beforehand. And that question about, if I've had COVID-19, am I now protected, is a very common one. I think we'd like to know that. And I think folks in the community would like to know that. And then obviously it's in the popular press, but it's still obviously something that we talk about a lot, which is, having a vaccine for this will be something that will be essential for us. In terms of COVID-19, like the disease COVID-19 as opposed to the SARS-2 infection, I think we're very curious about therapies for COVID-19 and are there unique aspects to this infection, both for treatment of that infection, and you've seen lots and lots of different ideas floated out there, and many small series of trying different immunomodulators to try to treat the disease, as well as antivirals. So I think that is a hot topic, and obviously a place where we would like to do rigorous investigation and not just report short series of things we tried. And I think that's been a focus here, a lot of discussion here about how can we be more rigorous about that. And then I think there's a ton of discussion in the critical care community about strategies for care of the critically ill. Are these patients different than the usual patients with ARDS? Do they look different in terms of their lung mechanics? Do they have different manifestations of other organ systems? There's a lot of discussion early on in the series that we had here out of Evergreen Hospital about cardiac dysfunction. So is cardiac dysfunction a big part of this? Is there a cytokine storm picture that leads to progressive shock? Is there a predisposition to clotting that's distinct from folks who normally have ARDS and viral pneumonia and infection? So these strategies for care of the critically ill is a topic that we spend a lot of time thinking about and talking about as well. And I think it is both in terms of taking care of the entire patient, as well as what we do with the ventilator. You've seen lots of discussion perhaps about how we support folks in terms of, do we put them in a prone position or not? There's much discussion about, should patients who are not intubated be in a prone position or be face down to try to open up parts of the lung that are getting more collapsed. Particularly if you don't have access to as many ventilators as you want, is that a way to spare patients from needing to be intubated? How do we use high flow nasal cannula? All of these things are topics of great debate and things that we're hoping to continue to study. On a basic science level, I think understanding the mechanics of what's happening to patients post-mortem has been an area of interest for us as well. So trying to understand, do we see more clotting? Do we see microthrombi in the lungs of patients? Do we see evidence of inflammation in the heart? And are those all things that are potential targets for next steps and interventions for the future? So I think these are all the topics that we spend a fair amount of time thinking about and talking about, and it's what we're collaborating on to think about in terms of research. I will add that early on, we had a fair amount of partnership with our engineers to think about what can we do in terms of mechanical ventilation, and we've done less of that in our community because I think we have felt less of the pressure that we're going to need to do really outside the norm strategies in terms of mechanical ventilation and like sharing ventilators and things like that. But that's obviously been stuff that's been talked about and tested in New York City and other places as the pressure on having enough ventilators became very real. So what do we need moving forward? I think testing is still a big deal, and our testing turnaround time right now is about 6 hours. For our virology lab, we have rapid tests that take about 1.5 hours to 2 hours. But we still would love to have more access to testing and trying to figure out what's the best strategy for testing. And I think that includes nasopharyngeal swab PCR testing, but also antibody testing. So I think the place that we're spending a lot of time now is thinking about how quickly and how effectively can we ramp up antibody testing? And then what does that mean in terms of immunity? I think we really need to understand that as well. And then there's obviously ongoing needs around PPE, personal protective equipment, and how we have enough personal protective equipment. We're already having discussions here about the second wave of this virus. And so we haven't come down from the first wave. We're still at a plateau in our hospitals. But I think we're already thinking about, if we start to loosen physical distancing, what will it look like in terms of a second wave, and are we going to be ready for that second wave? And then obviously the next phase of getting to the point of having a vaccine, producing it large scale and distributing it to folks so that people are tested, are treated and hopefully protected moving forward. I have much more I could say. I'm going to stop there and say thanks to Deb for inviting me to come talk with you, and transition to being able to talk with her a little bit more and answer any questions that might have come in. So I'm gonna stop sharing my screen so I can see you, Deb, and then maybe we can do some discussion, you and I.
Great, thank you so much, Trish. That was a great view, and you know, as we said that, you know, it's funny, isn't it, the timing of your talk, right? We originally had planned this when you guys were in the heart of it, and now certainly, right, positions have changed, but still there's so much to cover. Let me start with diagnostics, right?
Yeah.
Because as you say, you guys were in a very interesting and unique position, and let me give context for the audience if they're not familiar, right? That University of Washington has always been a leader in molecular diagnostics against infectious diseases, right? I mean, all of us, even in Boston, right? Many of our samples for, you know, specialized tests would go to you guys. Can you give a little bit more of that history for people? And then I want to get into specifics about, you know, your positivity rates and your increased capacity, but just give people that history so they understand that.
Yeah, I mean, I think we have we have a really strong lab medicine department that has partnered with our infectious disease division for many, many years. And I think they've been leaders in doing this type of testing for a long time. And in this setting, when investigators in Wuhan published the sequence that they were using to do PCR testing for coronavirus, the folks in virology, specifically Alex Greninger, early on just went ahead and started to develop a test for this. And so before we even saw coronavirus here, we had a test that was ready to go. And really, we were just waiting for it to be approved. You know, in the early phases of this pandemic, the desire was for us to use only the CDC testing. And so I think we had a little bit of tension while we said we had a test and we were ready to go, and we weren't being able to go. But relatively quickly, we were able to get through that and start using that test. So there's been a long history of really outstanding work in our virology lab and our other aspects of lab medicine. And so I think their ability to ramp up and do this quickly is a testament to that. I will add that it cost a lot of money to do that, and folks were willing to make that happen. And it's just worth acknowledging that our leaders in the institution were willing to do that so that we could have the test available. And so we went from having a few hundred to 1,000 in the probably first week. Jeff Baird, our chair of lab medicine, was really committed to increasing capacity, and then they were able to get up to 5,000 tests a day pretty quickly. Granted, they were working literally 24/7 to do that.
Yeah. It's impressive leaders with a lot of foresight, right? How that can impact.
Yeah.
You know, so you say it's interesting that you tell me your positivity rate is around 9 to 10%. Right?
Mm-hmm.
As you know, in many places, particularly where, you know, the disease is rampant now, right? Our positivity rates are up, you know, well above 20%, which is suggesting we're not testing enough. What do you think? I mean, are you trying, you know, the ideal is less than 1%. It means you're testing widely so you can pick up every case. I know this is a hard thing. Do you think that there's a sweet spot? Do you think you guys are in a sweet spot?
I think that there's probably some space for us to continue testing. I think one thing that's interesting is, you know, we started testing folks before they come in for surgery, and now we're testing everyone who gets admitted to the hospital. And we're not picking up a ton of disease that way, but we are picking up some. So that's starting to be like a broader swath of folks that we're testing. I think that there's still opportunity for us to test more broadly, and that's exactly what we're talking about right now, is whether or not we start doing it more broadly. You know, our rate, we saw it kind of starting to go up, and we got up to about 15%, and then we've come back down to 9%, and we've been broader in our testing as we've gotten to 9%. So I don't know what that means. I do think that there's a lot less of it running around the community now than there was when we started. I think that that's probably true, and I attribute, at least, you know, I think largely to people doing physical distancing and the stay home, stay safe stuff. But yeah, I think we're probably not at the sweet spot, but moving towards it.
And so you're talking about getting admitted, you know, gets tested now.
Mm-hmm.
What about in the community? You know, what about this notion of whoever wants to be tested can? Are you guys approaching that? Is that what you aspire to?
We're not there yet. That's definitely not the case. But we do have drive-through testing for folks in the community now. So those drive-through testing spots that were once really designed for mostly our employees and folks who were related to folks who are employees, to be honest. Now we have community testing. It's not just you can drive up and drive through, you have to have an appointment. And what I would say is we're still mostly testing people who are symptomatic. So the part where we would get to the point where we're starting testing asymptomatic folks, we haven't gotten there yet.
How about healthcare? So, you know, what are you doing there? Are you routinely trying to, you know, test all healthcare workers symptomatic or asymptomatic, or is that also still focused on symptomatic?
So we're still doing symptomatic healthcare workers. We're in discussion about whether or not we want to broaden that to test everybody. I think that that's an interesting space, because if you get tested and you're negative today, and then you go about doing your work, what does that mean about being negative 3 days from now? So I think we're having a lot of debates about what really makes sense in terms of testing folks. When we do contact tracing, obviously, so if somebody is positive, we have tested other folks who are around them, but we haven't been doing broad testing of our healthcare workforce to date. Now, there is more and more discussion of that in Seattle at a bunch of different institutions about starting to test everybody in the workplace. And I don't know this for a fact, but I have heard that we're going to start doing that at places like the Fred Hutch Cancer Research Institute. So I think we're moving into that space and starting to have those conversations as we feel like we have the capacity to do that testing, but we're trying to pause and make sure we do it as wisely as we can.
And presumably that why testing at the Hutch or other places is in the hopes of being able to reopen and get people back to work.
That is yeah, and that's the phase we're in right now, is we're trying to figure out how do we safely reopen things in a stepwise fashion. And the same thing is going on in conversations about the businesses in the area. Like, is Amazon going to open again? And if so, are we testing folks before they go back to work? What are we going to do with the university? The university right now is closed, is study at home through to the summer. And when will we start having school again? Things like that. So I do think we're in the phase of having those conversations. We're not in the phase of having figured that out, but we're definitely talking now about reopening and what that would look like.
Can you be a little bit more granular about that? So if you were to, if you or, the Hutch are going to test, everyone coming back to work, as you pointed out, you would have to continue that on a regular basis. Do you retest everybody every day? Every week? What is the thought process around that?
Yeah, I think the answer is I don't know. But I think it seems unrealistic that we could test every single person every day who came to work. That would be beyond the capacity of what we could do right now. If you looked at all of our sites and all the people coming to work, I don't think that we can be able to do that degree of testing. And our turnaround time isn't fast enough right now, right? We have a limited number of tests that come back in 1 to 2 hours, but most of our tests are coming back in 6 to 8 hours, which presumably would be the end of your day if you had worked. So I don't think that that's realistic right now for us to do that, to be honest. Whether or not we do some kind of surveillance testing of folks, maybe, but man, I still don't know how we operationalize that in a realistic way. And I think that's where people are also interested in antibodies. Like, will we learn that having antibodies is protective? And I don't think we know that right now. We extrapolate from other diseases and say maybe. But would we feel different about folks if they were antibody positive? Interesting. I mean, there's some, as you know, there's some evidence out there, some reports out there that people have cleared and then have been tested positive again for SARS-CoV-2. So I don't know. When do we say that we really know you're not gonna be a potential vector? I think that's really hard. And it's why I think we keep saying to everybody they have to stay home if they're sick at all, and they have to wash hands religiously and all of those things that I think are also essential to us trying to keep folks safe.
Let's talk about,
what do you think, Deb?
No, you're raising exactly all the same questions that we're in the midst of discussing.
Yeah.
Certainly there's concern that because we don't know, that people might misinterpret, right, and think that they're protected and they're not, right? And the consequences of that and the harm that could emerge is certainly concerning. And so one needs to be very cautious to do this in the absence of real science.
I agree with you completely. And I think we want some things to be true that we don't know are true. And so I think we have to be cautious in that space.
Right. So we're also desperate, right? Desperate to do something and intervene, desperate for life to go back to normal. So let's talk a little bit about desperate, to intervene. So as you know, so many clinical trials are going on, right? Therapeutics. data is being leaked out prematurely in some cases. Uh, you said things are, you're trying to really coordinate. How have you managed to coordinate that kind of almost chaos in the hospitals, right? Competing clinical trials for drugs, if you're enrolled in one, you can't get another. How have you guys coordinated and managed that?
So we have mostly funneled it all through. So we have a central coordinating group that's out of our Institute for Translational Health Sciences, or ITHS, that is bringing together all the studies and prioritizing which studies we're enrolling in across our institutions. So that's the first part, is that it's coordinated through the ITHS. And we have then prioritized certain studies. And then we have a team that is a collaboration of infectious disease physicians and pulmonary critical care physicians that have put together a guideline of how to stepwise think through the different studies that people can be enrolled in and what we're doing across sites. It's imperfect. Let me just say that up front. It's not perfect at all, but we have been trying to hold to the principle that we'd like people to be enrolled in trials whenever possible and not just do stuff. Because I think this is a tough space, right? People want to do something, and sometimes that leads to a lot of variability in practice, and we're trying to avoid that as much as possible. We were early adopters of giving people hydroxychloroquine. We have subsequently, participated in the PEDAL study to look at hydroxychloroquine as opposed to just giving it. Similarly, we were doing relatively frequent use of tocilizumab, and I think we're trying to do that in a little bit more rigorous way as well. So through ITHS, through collaborations between pulmonary and critical care and infectious disease, I think we're trying to be structured. And I don't want to give the impression that we're perfect on this, because we're definitely not. But I think that spirit of as much as possible, people should be as part of a study as opposed to just individual practitioners making a decision to try something.
But on a practical level, what does that mean? Patient X hits the emergency room, and or gets admitted to the floor. Is there a coordinated way that someone goes and says, oh, based on this, we're going to send it to that study as opposed to, a different study?
Yeah, we have folks from infectious disease who are on pager to call and talk through that, and they've been the point people for that. What that doesn't include is things around anticoagulation, because there's been a lot of discussion about increased coagulability and microthrombi in this disease. So that is a place that we're still trying to figure out, to be honest. But around other interventions, we've coordinated through a point person in infectious disease. And I'd say our teams have been really good about partnering with infectious disease to kind of think it through on each individual patient. And I think communicate to the folks who are on service what trials we're enrolling in, so people know up front what the things are that they could do. And we were early in the remdesivir trial as well, so that was the first one that we were in. Now we have the PEDAL study, so we're trying to make that transparent to people. And I would say that's really the infectious disease team that has shouldered a lot of that work and collaboration.
Then moving to kind of the clinical care of patients, you and I were chatting a little bit about this before the seminar, and that is that, someone comes in, right? We use this term ARDS, and we think classically of ARDS in one way, which maybe you can elaborate on why I think we think that's a flawed way to think about it. But then there's literature, suggesting of, well, someone with this clinical syndrome of ARDS should be treated one way, and yet there's features of it that are different and that don't fit that. Should we not be using those guidelines? Should we be, doing something new and different? How do you think about that?
Yeah, so I think this is obviously a big topic in folks in critical care right now. And I think a lot of it has been fed by discussions. Gattinoni wrote a kind of research letter that said maybe there's two phenotypes of folks with ARDS. So
Well,
to
just
go back to your first question.
Go back to define what ARDS is for folks.
Go back to that. So ARDS, the S is syndrome, right? It's not a disease, it's a syndrome. And it's defined by having 4 characteristics that lots of people could have, right? That they have something acute within the last 7 days, that they have bilateral opacities on their chest radiograph that aren't some like things that we wouldn't think of as ARDS, like effusions or nodules, that it's not all explained by heart failure, and that they're hypoxemic as defined by a PaO2 to FiO2 ratio.
And this is what people are dying from.
Let's just say it again.
And this is what people with COVID-19 are dying from.
Yeah, I mean, I think some of the patients are dying from shock and overwhelming shock, really, whether that's cardiogenic or septic. I think it's interesting also to debate and discuss. But yes, this is the thing that's getting people put into the ICU and intubated and supported with a mechanical ventilator is ARDS. And I think the S part of it says there's lots and lots of different ways to get to looking like you have those 4 characteristics. And probably there are lots of different phenotypes, different types of folks within that big bucket that's called ARDS. And I think what we'd like in critical care is to understand those different groups or cohorts of folks within the big bucket of ARDS and target our therapies more directly towards those people. And there's an easy way to think of it is some people have particularly stiff lungs in the setting of ARDS, and some people have less stiff lungs in the setting of ARDS. And some people respond to certain things we do with the ventilator, and some people don't respond to certain things we do with the ventilator. And I think it could be a lot more nuanced than that. But the long and short of it is that syndrome puts a lot of different people in the same bucket. And I think the question that you're asking, and I think the question people are asking in general is, are the interventions that we've shown before for ARDS, do they work for this cohort of people with ARDS, or is there something different about this ARDS? Or maybe, are there different groups within the big bucket of ARDS, even within people who are getting ARDS secondary to COVID? So I think I might slightly differ from you on this one. I think there's always been a lot of heterogeneity within people in ARDS, and I still think there's heterogeneity in the patients who are presenting with ARDS associated with COVID. You know, we've had some people who look like run-of-the-mill ARDS, very stiff lungs, exactly like we see all the time. And then there are some people who are less stiff. But I had patients who didn't have really low compliance lungs and would fit the bucket of ARDS before as well. So I think it's always been heterogeneous. I think we're seeing that heterogeneity here as well. And then if you want to say, well, if it's a heterogeneous group of people, should we be doing the same thing for everybody anyway? I think it's fair to say probably not, but we haven't come up with the nuances to say, if you're in this bucket, let's do this. And if you're in this bucket, let's do that. And I think that's what Gattinoni really said. He said, there's some people who have particularly stiff lungs, and there's some people who have less stiff lungs, and maybe we shouldn't treat them all the same. And I guess what I would say from that is, we should start with the principles that we know, and then we should treat our individual patient and think about what's going on with that patient and not be so rigid that we do only this. We look at the person in front of us and try to treat them as best we can. And that becomes challenging when you have hundreds of intubated patients in a hospital and a limited number of intensivists. So figuring out how we get intensivists to be part of those teams and thinking about the nuances of the ventilator, I think is still important.
Actually, Trish, I think you and I are completely agreed about the heterogeneity of ARDS, which is why I hate the definition of ARDS. You know, the basic science and part of me wants to actually, you know, create the buckets based on the underlying cellular and molecular features.
Yeah, I think that, I mean, that makes all the sense in the world to me, and I wish we were there because it's too dirty the way it is, right? It's way not clean enough to say, this is how we should treat this patient.
You know, time limited, but I want to ask this, and that, you know, you alluded a little bit to, okay, you identify someone and then you do contact tracing.
Mm-hmm.
Do you do it manually? I mean, Seattle, we think of all this high tech, you know, apps, you know, these kinds of things. How are you guys doing it, or how are you, you know, how do you aspire to do it?
Well, I think we aspire to do it electronically, but we're not, or technologically, but we're not there yet. But there's lots of discussion about how smartphones and things like that could be part of how we do contact tracing. And I'm not part of the Seattle King County Public health group, so I don't want to speak for them too much. But there's a lot of discussion about how we might do that more effectively without the kind of people power. Right now we're doing it people power. And so, one example of what we're doing is we're sending people out into skilled nursing facilities and testing everybody in the skilled nursing facility to see what the spread is within that institution. We're going out and contacting folks and saying, who are people that you've had contact with, and sending those people for remote testing, drive-through testing and things like that. So we're still relying on people power. We haven't gotten beyond people power yet. And so I think that's a space that we would love to take advantage of the fact that we have a big tech community, just like you have a big tech community, to figure out ways to do this more scalable, right? So that we can actually I think that's going to be an important part of how we get back to life. The way we were living it in some semblance from before is to be able to test and then do contact tracing.
So have you guys established collaborations with your tech community to try to take that on?
Well, the best collaboration I think we have so far is with Microsoft, and Microsoft has partnered with us to have this system so that we can know where we stand across the state in terms of beds, vents, patients, PPE, things like that. And that partnership with Microsoft has been essential to the thing that I called the RC3, the Regional COVID Coordinating Center. So yes, we are partnering with folks, and that would be the strongest one that I could cite right now. But I think there is ongoing discussion with other technologies in the area to see what else we can do. That would be the one that I think has come to fruition the most so far.
Okay, because of time, I'm just going to ask one last question. You kind of alluded to the little bit of the ethical challenge should you have gotten to that surge. Fortunately, you didn't get there. Can you give a little bit insight to how hard those discussions were, kind of what the things you considered, and maybe even some of the guidelines you were preparing to implement, and the difficult choices you were going to have to make if you had reached that point?
Yeah, and so a colleague of mine, Mark Tonelli, and our chair of our Department of Ethics and Bioethics and Humanities, Denise Tazinski, kind of led that effort in collaboration again with our regional disaster coordination group that is in existence way before COVID. And they actually, when the original SARS epidemic happened, had worked on this a fair amount before. But the protocol would be that we would have a triage team that was not the clinicians who were taking care of patients, that would be discrete, that would be a group that was behind the scenes and not identified, who we had an algorithm, or we still do, I don't know that we won't need to use this someday, that took into consideration what we know in terms of things that are associated with a worse prognosis, without absolute cutoffs, but with an attempt to try to prognosticate on the likelihood of doing the greatest good with the resources that we have. And I think our goal was to avoid a first come, first serve situation, and instead try to do the greatest good for the most people. And that would mean being able to prognosticate to the best of our ability. And that could include things like comorbidities, age, other organ failure, et cetera, in terms of making those decisions. I think I will tell you the one thing that was the most controversial in our community was the discussion about whether or not a healthcare worker status should fit into the triage process. Meaning, do we prioritize healthcare workers as part of that algorithm? I think that that's an interesting space, because on the one hand, those are folks who are taking risks, and we want them to know that we care about that. And we hear from the community that they are very supportive of that. On the other hand, every time you advantage one group, you disadvantage another group, and you often disadvantage already disadvantaged groups. So there has been a lot of discussion about that part of the algorithm. And there was an interesting piece in New England Journal of Medicine that advocated for that. And we talked about it a lot here. And what I would say is we actually have bumped it up to the level of the state to have further discussions, because I think we don't want to disadvantage having our folks want to come to work and know that we care about them and want to take care of them. At the same time, we don't want to disadvantage under already disadvantaged groups. So there's a lot of sticky ethical aspects to all of this, and talking about it in abstract is not so bad. Talking about it in real life is a lot more challenging.
Okay. The time, I think I have to stop, but thank you so much. You know, that was really insightful and really appreciated your sharing your experience. We're going to, you know, you guys are ahead with regards to how do you reopen. So, you know, we may touch base again to see, you know, how you guys are doing it. Clearly, you guys were in a unique position, right? You had, you know, flu surveillance in place. You were ahead in diagnostics, you know, so that your test was there before you had your first patient.
Yeah.
So you guys were
It made a big difference. You're right.
You guys were in a unique position.
I think just to say this, I think the part that's inspiring to me is how much people have been sharing. You know, during all of this, I was texting with folks at the Brigham and MGH and, you know, talking to friends in New York City and talking with you and others. And I think that that's inspiring to me about the medical community, that we keep sharing around what's happening with us in our hospitals, what's happening with us with our science. And I think we need to continue to be so collaborative to get through this. So it's my pleasure to spend some time talking with you.
Agreed. That's what happens when we're all desperate. Thank you so much, Trish.
Bye. Thank you.